On this episode of the ASC Podcast with John Goehle, we discuss the latest news and information, including prior authorization changes, a recent lawsuit related to billing, CON changes, fire extinguisher requirements, medication management of high alert medications with reversal agents, and supply storage outside of the ASC. In our focus segment, we will discuss a recent quality, safety, and oversight memo clarifying the roles of accrediting organizations and the state survey agencies when an ASC's deemed status is temporarily removed.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 273 of the ASC Podcast with John Goehle, recorded on April 30th, 2026 from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So it's getting awful crowded in the studio right now.
It is.
We have 3 dogs with us. As long-term listeners know, we usually have 2, but one of Rosie's puppies is visiting us for a week. And
he is the biggest of them all.
He is the biggest of them all.
Male,
and I hopefully the microphones are not picking up all of the panting going on here.
And the tail wagging,
and the tail wagging.
Walls. And
it's been a very busy period with us again. I know it seems like we're always saying that, but it is really true. So we've been very busy with surveys. We have new centers opening up. And, of course, the annual boot camps have been going on this month and moving into May. We just finished the Director of Nursing boot camp in early April, and all the recordings are done, and they're now going to they now have been posted to the on-demand version of the DON boot camp. So if you weren't able to participate in the April Director of Nursing boot camp on asc-central.com, you can now sign up for the on-demand version of it, which includes everything that you got, all the things that you got with the boot camp, which includes the optional weekly drop-in sessions, the recordings, all the resources that come with it. The only thing you don't get is that interaction during the 4-day virtual conference. And next is our Administrators Boot Camp. The annual Administrators Boot Camp is coming up May 26th through the 29th, and we're going to provide links to sign up in our show notes here. And the boot camps have always been very popular. I think we have over 400 graduates now between the various boot camps that we do, and we've been doing it for about 5 years now. Actually, it is our 5th year. And you're going to find the boot camps are very reasonably priced with discounts for clients of Ambulatory Healthcare Strategies. And all of our boot camps, of course, are included in our comprehensive ASC Central Premium Access program. the job of an administrator and director of nursing is so difficult in today's environment. And one of the reasons that it's become so popular, the boot camps have become so popular, is because it really is top-notch education and to prepare you for the tough job that you have as an ambulatory surgery center leader. So definitely something for you to look at. And for more information, visit asc-central.com. We also want to kind of point out our premium access program at asc-central.com has really been taking off recently, quite substantially within the last couple months. And that provides access to all of our education programs at ASC Central. Speaking of which, our new ASC Central studio is shaping up, isn't it, Sue?
It is, and lots of new equipment.
Yeah.
You're going to have to figure out how to use and
I know.
get it all in place. It's been a big job for you.
It's a big step. I guess with how tight it's getting here in the smaller studio, we're really going to need it. But really,
Yes.
what's involved here is it's a whole new look for our virtual conferences, much more of a news station type look. Where we have a central desk and multiple speakers are speaking at the same time in the same set, as opposed to the traditional or what you're often seeing with virtual conferences where everything is done through Zoom. And so we have new cameras on order. All of the testing is going to be done over the next couple months. We're looking at a number of new conferences this year. One is going to be the Quality Improvement Conference. We're going to be revising our infection control conferences, which we did about 2-3 years ago last. And of course, our very well-known multi-state conference. All of those things are in the works, but none of the dates have been settled yet. So more information to come on that, and very excited about using our new studio for that. So it's been almost a month since our last podcast, which we're going to try to avoid moving forward, given the amount of news we have. I think we're going to have to split some of our news between a couple episodes here. So, Sue, what news do we have?
So I wanted to just kind of summarize an article from April 21st in Ambulatory Surgery Center News by Robert Holly about prior authorization. So the United Health Group is signaling a clear direction for where healthcare is headed. Tighter cost control, more streamlined administrative processes, and a continued push to move care into lower cost settings, which is, of course, good for us. At a high level, the company's message reflects a broader industry shift. Insurers are not abandoning tools like prior authorization, but they're under pressure to make them less burdensome. And at the same time, they're doubling down on value-based care models that reward outcomes over volume, and they reduce reliance on hospitals. For providers, including ASCs, this creates a mixed landscape. Administrative friction isn't disappearing, but it might become more manageable. Meanwhile, opportunities are growing as payers actively steer patients away from high-cost sites like hospitals and into more efficient care settings.
Yeah, Sue, and we've actually seen that with our own healthcare plan, where both of us in the last couple I'm in a Medicare plan, Sue. Sue is not, because she's so much younger. But both of us have received emails within the last couple months, really kind of encouraging us as the consumer going to an ambulatory surgery center. Usually, of course, it's always been the doctors that do that encouragement.
Yeah. So prior authorization is a good example of that balance that we were just talking about. United Healthcare makes it clear that the practice remains central to controlling costs and ensuring appropriate care. However, the company is working to make it a faster, more automated, and less frequent process. The goal is not elimination, but to optimize it, reducing delays and provider frustration while they're still maintaining the oversight. And at the same time, the bigger strategic focus is on changing where and how care is delivered. Through Optum, United Health is expanding value-based care arrangements that align incentives around patient outcomes. So these models are already showing measurable reductions in hospital use, including fewer inpatient admissions and emergency room visits. This shift has direct implications for the broader care ecosystem. As value-based models expand, payers are increasingly incentivized to direct patients toward lower-cost, high-quality alternatives, which, of course, includes ASCs. And early results suggest this strategy is gaining traction. United Health leaders pointed to significant reductions in areas like skilled nursing facility utilization, reinforcing the idea that care is steadily moving away from traditional high-cost institutions. And stepping back, the financial results matter less than the trajectory. United Health Group is positioning itself for a long-term transformation, one that's focused on integration, cost discipline, and the system-wide efficiency. Elevated utilization and cost pressures remain, but the company is betting that better alignment of incentives and smarter care delivery models will drive sustainable improvement over time. So basically, here's the takeaway. The healthcare system is being reshaped around value efficiency and site of care optimization. Providers who can operate effectively within that framework, delivering high-quality care at a lower cost with less friction, are likely to be the ones who benefit most. So that's all good news for ASCs.
Yeah, absolutely. And I think we're definitely seeing that in the marketplace now, as we mentioned, even in our own healthcare plans, we're seeing that encouragement. And I think what I really like is now we're starting to see direct to the consumer work. And that's really what that article is talking about there too, is that it's traditionally been, going after the doctors to try to encourage that movement. Now we're going directly to the patient, which I think is much more effective. First of all, encouraging patients to become more actively involved in their care. But I do believe that, going directly to them and encouraging them or telling them that to have their doctors take them to a surgery center, it's going to be a lot more effective in the long term.
And from the April 24th ASC Focus, they talked a little bit about CON requirements being eased up in Maine and a couple other areas. So the Maine CON law changes. So Maine recently passed the LD 1890 to ease establishment of new healthcare facilities, including ASCs. This raises the CON review threshold from $3 million up to $7.5 million. This will take effect January 1st, 2027, and it will be adjusted annually based on the Medical Consumer Price Index. And for a broader state-level CON reform trends, South Carolina and Tennessee both repealed CON requirements for ASCs in 23 and 24, although in Tennessee, the implementation is still in process. Some of the items include that it applies to non-hospital ASCs, defined as not being affiliated with or controlled by hospitals, and requires new licensing rules, including Medicaid, with participation at levels similar to hospital-based ASCs, and charity care and a charity care provision comparable to hospital-based ASCs. And that doesn't take effect until December 1st of 2027.
There's interesting ramifications for this because, of course, during my entire career, which now is over 36 years, CONs have been a fixture in many states, and to see these starting to fall by the wayside, or even if they're still there, like in New York, for example, we know that they're much less stringent than they were before. I think that really indicates a big shift in the way we're encouraging competition in the ambulatory surgery industry. But, Sue, the other thing that comes out from this is the value of the surgery center license becomes less. In those states where you have very stringent CON rules, there's a barrier to entry, which shows up in the valuation of the surgery center. So that's one thing that I've been starting to notice as people are, I've had people ask me the question, well, how much is the license itself worth in a state that has a CON? And that goes to almost zero when there is no CON requirement in that state. They totally rely upon the licensing of it.
Yeah.
So one story that kind of caught our attention recently involves a major insurance carrier suing a large ASC operator and several Florida centers, alleging a long-running scheme to inflate claims. Now, we'll provide a link to the particular article here, which showed up in ASC News on April 22nd, 2026. So Allstate and its affiliated insurers filed the lawsuit in mid-April 2026, claiming the defendants billed for medically unnecessary services, unperformed procedures, improper coding, duplicate billing, unbundling, and exaggerated use of anesthesia. And they also allege that many routine pain procedures were moved into surgery centers primarily to generate extra facility fees that wouldn't have been paid in that physician office setting. And the insurers are seeking treble damages under the RICO Act, and that's triple the actual losses plus attorney's fees. Now, it's important to note that the defendant strongly denies the allegations, calling it a legitimate disagreement over complex billing and reimbursement rules. And says it's not fraud. And they also say that they will defend the case very vigorously. Regardless, though, of how this specific case turns out, it shines a very bright light on a much bigger issue every ASC needs to pay attention to. And I think one thing that's important is this isn't, a small surgery center. This is a major national organization here, and they're being accused of all those things, mentioned earlier, including, billing for unperformed procedures, which is extremely serious. So the bigger picture is commercial payers, especially auto insurers and large health plans, are increasingly aggressive about auditing and litigating what they see as abusive billing practices. And when claim patterns look like systematic upcoding, unbundling, or steering cases to higher reimbursement, it can trigger everything from post-payment audits and recoupments to the False Claims Act investigations and civil RICO lawsuits. And I think, artificial intelligence, which of course we're doing a series on right now, makes it so much easier for these insurance companies to identify these types of situations. And by the way, on our side, it also can help us to identify situations that might actually trigger an insurance company to look further into it. Even if your center has zero bad intent, in other words, you're not doing this on purpose, weak documentation or inconsistent coding can make you look like you're playing games. And defending a lawsuit is expensive and distracting no matter who wins. And I think that's an important point to make, is that even if in the end you win, you might end up losing because you have to spend so much money in order to fight it. And this isn't just a big chain problem. Smaller and independent ASCs get caught in audits and repayment demands all the time for those very same issues: missing or insufficient documentation to support medical necessity, billing supplies that are already packaged into the ASC payment, using the wrong modifiers or CPT codes, or performing procedures in the ASC that the payers believe belong in an office setting. So here's a key takeaway. You need a strong, experienced medical biller who knows ASC-specific rules inside and out, and you need thorough, contemporaneous documentation that clearly supports every service, supply, and level of care that you bill. And this means that you have to be very careful about bringing into ASC billing somebody that might have experience or more experience in the office setting. So you want to make sure that your operative report, your anesthesia records, and progress notes tell a clear story that documents the medical necessity of those procedures. You also want to avoid unbundling, which should be included in the facility fee. And then you have to have clear policies on when a case belongs in an ASC versus an office. And then run regular internal audits of high-risk areas like pain management, spinal procedures, and supply billing. And consider a compliance review or audit of your top payers' policies at least annually. In today's environments, clean claims and defensible records aren't just about getting paid faster. They're your best protection against repayment demands, those audits, and the lawsuits that can drag on for years. We'll keep an eye on this, Sue, I think, just to see how it develops, and we're bringing you updates as it goes along. Let's talk about some recent events that we get either from our clients or from our weekly drop-in sessions or surveys that our survey team. Sue, we have what do we have now? 7 surveyors at Ambulatory Healthcare Strategies.
Yes, I think so.
It's incredible. We just keep getting more surveyors employed, as well as people that we have that have become surveyors. Very exciting. So here's some things that have come up recently. Let's start with fire extinguishers. A center recently asked, how many fire extinguishers do I need? Where are they and what type? So we put this question to our life safety team, and the rules are more detailed than most people realize here. So the maximum travel distance between fire extinguishers in your surgery center is 75 feet. So that's one thing to keep in mind. And then remember, there's different types of fire extinguishers. I'm not going to go into a lot more detail other than give you the numbers. So you need to have one 2A extinguisher per 1,500 square feet, a minimum of that number, I should say. For flammable liquids in procedure rooms, you need to have the right B ratings, either a 10B, 20B, etc. rating. And for operating rooms and procedure rooms, a standard ABC dry chemical usually works fine for electrical fires. True clean agent extinguishers are nice, but they're not required by the code. And then also make sure that your extinguishers are mounted at the correct height, they're clearly visible, and that your staff can actually find them in a hurry. And we actually ran into this recently where a fire extinguisher was mounted too high, and some of the employees who are relatively, shall we say, short-statured, would not be able to easily get that off of the hook there. And while we're on the subject, Sue, why don't we just mention a couple things about fire extinguishers? They need to be visually inspected every month by your staff, and then once a year they need to be looked at by a professional fire extinguisher company that checks to make sure that it's properly functioning, that it's charged properly, and looking for any deformities in the device. And then I think it's every 6 years it has to go through a thorough evaluation, and often it's during that 6-year period that they cycle them out. We were talking just before we recorded here that a great thing to do during your fire drills is to, like, maybe once a year use expired or low fire extinguishers and then just discharge them, have your staff discharge them, learn how quickly they empty. People are shocked by how little amount of time it takes before you completely discharge a fire extinguisher, especially the smaller ones.
People know about the aim first, but I don't know if they always realize how important that is.
Yeah, the ones that we have at home, we have a couple here in the house, in the studio too, and they would not last very long. They're not the size of the other ones. So stay away from those really small ones.
And just that hesitancy of doing that, it's like pulling a fire alarm.
Yeah.
If you're not used to doing it, you have never done it before, it really is good to have that practice.
Yeah. We also had some issues with regard to high alert medications and the reversal agents. So if you stock a high alert med that has a reversal agent or an antidote, you must make sure that you have that agent in stock in the same area with directions for use. This isn't always cited by surveyors, but be prepared for it. Make sure that that these reversal agents, of course, are on your formulary also.
And I want to just jump back to the fire extinguisher. This was something you noted the other day. Make sure when your staff is checking that they note the actual date, because it's supposed to be once a month. And a lot of times, I think many centers will just kind of do April, May, June. Yeah. But if you do it at the beginning of April and not till the end of May, that's more than 30 days. So put the date.
Very good point. So an interesting situation, a surgery center was storing supplies, including sterile packs and procedure items, in a room that was not part of the certified ASC space. It was located in the same building, but outside the walls that define the Medicare-approved ASC footprint. It was actually, I think, 2 stories up, so the supplies had to be moved also on a elevator, which is another whole issue. And the way this was found was a state surveyor walked in on a complaint survey, saw it, and cited it immediately. So here's what the problem is here. Is CMS, as we've talked about many times over the years, requires every ambulatory surgery center to operate as a distinct entity under the conditions for coverage. And that means that the entire physical space where you provide surgical services, including every storage area for supplies that touch patients, has to be within the surveyed and approved ASC premises. You can't just use an extra closet, a shared utility room, or space belonging to another tenant or practice down the hall. And you might ask why this is a problem. So it is because the outside room isn't under your direct control for temperature and humidity monitoring, for infection control purposes, for security, or for fire safety. And the surveyor, really can't inspect it as part of your ASC, so they have no assurance that those supplies are being stored safely. It does violate the physical environment condition number 416.44, and in many cases, infection control standards that require sterile supplies to stay in a designated clean area inside the facility. And consequences might be bigger than you think. This often gets written up as a condition level citation, not just a standard level paperwork issue. So the bottom line is, if the room isn't part of your surveyed ASC, the supplies don't belong there. Keep everything inside the lines. It keeps your survey clean and, more importantly, keeps your patients safe. So in March of this year, CMS issued a quality, safety, and oversight memo that has significant ramifications for the ASC industry. It's QSO 18-12, and it clarifies the roles of accrediting organizations and state survey agencies when an ASC's deemed status is temporarily removed. So before we dive into the specific details of that memo, we'll talk you through the key foundational concepts every ASC leader needs to understand, the real difference between deemed and non-deemed status surveys, and exactly what condition level citations, standard level citations, and immediate jeopardy situations mean in practice. So we'll pick that right up after this short break. Stay with us.
Every ASC professional knows that running a surgery center takes knowledge, skill, and a strong support network. That's why we created ASC-Central.com, a place where ASC leaders and staff can learn, connect, and grow together. ASC Central is a comprehensive hub for education and professional development in the ambulatory surgery industry. Our leadership boot camps, on-demand conferences, and membership programs are designed to meet the needs of administrators, nursing leaders, medical directors, business office managers, and anyone committed to excellence in outpatient surgery. Our leadership boot camps are guided, mentored programs that help develop the next generation of ASC leaders. Whether you're new to your role or looking to refine your skills, these boot camps provide the structure and insight you need. And many of them offer AEU credits for CASC certified administrators and IPCH credits for CAIP certified professionals, supporting your ongoing professional certification. ASC Central's on-demand educational library gives you access to in-depth programs on compliance, quality improvement, infection control, credentialing, finance, and more. These full-length virtual conferences are designed to be both informative and engaging, not just check-the-box webinars. Many also include CASC and CAIP continuing education credits. For those who want ongoing learning and connection, ASC Central offers flexible membership programs. The patron membership gives you access to Zoom discussions, key conferences, and a robust resource library. The Premium Access membership adds full access to all boot camps, private consultations, staff training, exclusive content, and ongoing support from top experts in the ASC field. If you want to be part of a community dedicated to raising the bar in ambulatory surgery, visit asc-central.com or email us at info@ascpodcast.com. ASC Central, bringing ASC professionals together to learn, grow, and thrive.
So in our focus segment today, we need to discuss a recent CMS Quality, Safety, and Oversight memo, QSO 18-12. It was revised just last month on March 25th, 2026, and it clarifies the roles of accrediting organizations, or AOs if I refer to the initials, and state survey agencies, which we refer to as SAs if I use those initials, when an ASC's deemed status is temporarily removed due to condition level noncompliance.
But before we get into the specifics of that memo, let's make sure that everybody's on the same page with two foundational concepts: the difference between deemed and non-deemed status surveys, and the three main levels of citations that you can receive during a survey: condition level, non-condition or standard level, and immediate jeopardy. These are the building blocks that determine how seriously CMS treats a survey finding and what happens next.
Let's start with deemed versus non-deemed status. So many ASCs actually choose deemed status, and here's how it works. When you're a deemed status organization, you contract with a CMS-approved accrediting organization, or AO. And you might want to refer, by the way, to our recent series on the accrediting organizations. Over the last, I think it was about 3 or 4 months, Sue, we interviewed people from 4 of the 5 accrediting organizations that are out there. And make sure that you take some time to listen to those episodes. So the accrediting organization surveys your center using standards that CMS has already approved as meeting or exceeding the Medicare conditions for coverage, or the CFCs. And if you pass, CMS deems you compliant with the Medicare requirements. When you contract for a deemed status survey, you don't get routine surveys from your state survey agency generally. By the way, that can change. Like in Pennsylvania, the state's coming out every year anyway, but they're not doing the CMS survey every year. They're just doing the state survey. And the accreditation organization handles your Medicare compliance oversight. Now, non-deemed ASCs, sometimes called state-surveyed ASCs, don't use an accrediting organization for Medicare purposes, or they're not accredited at all. For example, in those states that don't require an ambulatory surgery center to be accredited. Instead, the state survey agency, or the SA, which is your state Department of Health usually, conducts the surveys directly on behalf of CMS to verify that you meet the conditions for coverage. You still have to comply with the exact same federal rules, but the surveyor wearing the badges from the state, not from your accrediting body. Some ASCs choose this route and others fall into it if they lose or voluntarily drop their deemed status.
And as I mentioned, once a survey happens, whether it's deemed or non-deemed, any deficiencies fall into 3 levels of citations. So at the lowest level, you have non-condition level citations, also called standard level deficiencies. These are issues with specific standards inside a broader condition for coverage. Maybe a documentation gap, a minor infection control lapse that doesn't affect patients, or a policy that's not quite perfect. These are important to fix. You still need to submit a plan of correction and correct them, but they don't usually threaten your Medicare participation on their own. And then one step up from that is the condition level citations. This is where the survey team determines that you're not meeting an entire condition for coverage, one of the major buckets of requirements that define safe ASC operations. If you look at the conditions for coverage, there are conditions that don't have any letters or numbers after the condition. For example, 416.51 conditions for coverage. Infection control. The ASC must maintain an infection control program that seeks to minimize infections and communicable diseases. If you don't even have a program, you would have a condition level citation. Also, if you don't have a robust program, even if you have one, the surveyor might raise the level of the citation to condition level. Lacking all of the required policies and procedures on its own probably won't raise to a condition level. But if you don't have all of the required policies and procedures and you didn't appoint an infection control coordinator that has documented training in ASC infection control oversight, then you're likely to have a condition level citation.
Sue, I'm sorry about that. I just noticed that there are a lot of run-on sentences there in my write-up. Sorry. So condition level citations are serious. They signal a systemic problem or a failure that could affect patient safety or quality. If you're a deemed ASC and a validation survey or complaint investigation turns up a condition level citation, CMS can and often does temporarily remove your deemed status. So this is important, and that's actually the subject of the QSO we're going to talk about in a few minutes. So going back to the levels of citations, at the very top and the most urgent is immediate jeopardy, or IJ. CMS defines this as a situation where your noncompliance has caused or is likely to cause serious injury, harm, impairment, or death of a patient. An immediate jeopardy is not a separate type of citation. It is a severity level that can attach to a standard or a condition. But when it's present, everything accelerates. You must correct it immediately, often within hours or days, and CMS can move very quickly toward enforcement actions, including termination from Medicare, if it's not fixed. Immediate jeopardies almost always trigger a condition level citation, and for deemed centers, the temporary loss of deemed status we just talked about. I should mention, too, in my recent experience as a surveyor and working with and talking to a lot of other surveyors, the number of immediate jeopardy situations that we are citing has increased quite dramatically recently. So I did want to mention kind of some pros and cons of deemed versus non-deemed status. So generally, you're going to, if you go with a deemed status survey, you're going to have a reduction in the number of surveys that you have. In other words, usually the state agency is not going to come out on a regular basis to visit your surgery center. So the only surveys you're going to have are going to be from the accrediting organization, which does both a Medicare certification survey as well as an accreditation survey. And this may reduce the frequency of state regulatory surveys. In other words, surveys that are done for your licensure. One big thing that we need to note is that life safety surveys are generally different. The accrediting organizations have recently had quite a reputation for being much more stringent than many of the state agencies when it comes to life safety citations. And one positive thing, I think, kind of a pro, is the predictability of survey timing. For example, if you're a deemed status organization on a 3-year cycle, you know that within probably 6 months of the expiration of your accreditation, that's probably when the surveyors are going to come out to do your Medicare deemed status survey. Whereas if the state is doing it, it could be years before you see them come out, and it could be any time during that year. So let's talk about QSO 18-12, Deemed Status Providers and Suppliers. And the title of this QSO is Clarification of the Accrediting Organization's Role when a Provider or Supplier's Deemed Status has been temporarily removed. And I'll provide a link to the information on this. So I'm going to quote some of the sections of this QSO here directly from the actual QSO. So it states that CMS may temporarily remove the deemed status of a provider or a supplier accredited under CMS-approved accreditation program when the state agency or federal survey team identifies condition-level noncompliance during a survey. The CMS location must advise the provider or supplier that its deemed status is being removed and that it is being placed under the state agency jurisdiction. The deemed status provider or supplier remains under the state agency jurisdiction until it either brings itself back into substantial compliance with the Medicare regulations or CMS terminates its Medicare participation. If the provider or supplier demonstrates substantial compliance with the federal standards to the state agency, CMS then will restore its deemed status. Upon notification from CMS that a deemed provider or supplier has been temporarily placed under state agency jurisdiction, the accrediting organization should confirm when the provider or supplier is due for reaccreditation. Accrediting organizations are to suspend or postpone any Medicare-related survey activities with respect to that facility while that facility is under a state agency jurisdiction, since CMS does not recognize the accrediting organization's deeming authority at that point for that facility during the period of condition level noncompliance. Furthermore, CMS will not recognize any accrediting organization's reaccreditation, recertification determinations regarding that facility until CMS determines that the facility has demonstrated compliance with those requirements. The suspension of deeming accreditation surveys for affected accredited providers and suppliers will also prevent unnecessary burden on those non-compliant facilities by allowing them to focus on coming into compliance with the Medicare participation regulations. Now, accrediting organizations may continue to conduct non-deeming accreditation surveys for such a facility while an accredited organization is under state agency jurisdiction. So hopefully that gives you a pretty good idea of what's going on. This is a pretty major change. And I think we, as surveyors, of course, are expecting a little bit more oversight than we've had recently by CMS, who is hiring independent organizations to do CMS validation surveys. Mm-hmm. And that we've talked about, Sue, before, but this whole issue with regard to complaint surveys done by a state agency, that is new, and that potentially has big ramifications, especially if you're going through a complaint survey. So just be careful in that situation and make sure that you're knowledgeable about what's going on. So let's take a short break, and when we come back, we'll talk about upcoming events in the ASC industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So the ASCA and SAMBA Conference and Expo is May 13th through the 16th in Washington, D.C. It's coming up soon, a couple weeks. Mm-hmm. We're going to be there with a big team. We're going to hopefully do 2 to 3 special episodes. And Ambulatory Healthcare Strategies and the podcast will have a booth there. So make sure you stop by and get some of the goodies that we'll have and find out more information about the wonderful services that Ambulatory Healthcare Strategies offers.
And the virtual conference for the ASC Administrators Bootcamp is May 26th through the 29th. And for more information, visit asccentral.com, and we'll provide a link in the show notes.
The Gulf States ASC Conference, which is the Alabama, Louisiana, Mississippi Associations Conference, is June 17th through the 19th at the Ritz-Carlton in New Orleans. The
Arizona ASC Associations Conference is June 24th through the 26th at the Sheraton Grand at Wild Horse Pass in Phoenix, Arizona.
And I'll be speaking at that conference. And the Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 22nd through the 24th at the Hyatt Regency Grand Cypress in Orlando, Florida.
The California, or CASA's annual conference and exhibits is September 2nd through the 4th in Monterey, California.
The Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is October 4th and 5th at the Eden Resort in Lancaster, Pennsylvania.
The Atlantic States ASC Conference, which is North Carolina, South Carolina, and Virginia, is October 8th and 9th, 2026 at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina.
The Ohio Association of Ambulatory Surgery Centers Annual Education Conference is November 11th through the 12th at the Ohioan Hotel and Event Center in Lewis Center, Ohio.
The Washington Annual Education Conference and Trade Show is November 11th through the 13th at the Tulalip Resort and Spa in Tulalip, Washington.
And I'll be speaking there, and we'll also be doing a special episode from there. And the New York State Association of Ambulatory Surgery Centers Annual Conference is November 17th through the 18th at the Desmond in Albany, New York. And we'll have a booth, and we'll be doing a special episode from there. Don't forget, on-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers Bootcamps are available on our sister website at asc-central.com. And remember, the ASC Director of Nursing Bootcamp has been updated with the recording from the April 2026 Bootcamp. And I do want to remind everyone to become a patron member of the podcast. Don't miss out on the benefits of joining our patron member program, which is available at asc-central.com. We have over 500 patron members at this point. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. And it's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to our regular drop-in Zoom sessions, typically held weekly, where you can engage with other patrons and our podcast team. But that's just the beginning, really. Your membership unlocks a wide range of resources, including access to some of our virtual conferences, including the Credentialing Conference, the Conditions for Coverage Conference, and the Medical Director Conference. And you also find valuable tools like sample policies, procedures, forms, and fire and disaster drill kits. Your support of the patron program helps us to maintain and grow the podcast, covering essential costs such as research, travel, equipment, and production. To learn more and become a member, visit asc-central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and any suggestions for future topics. Please reach out anytime at comments@ascpodcast.com.
A special thank you goes out to our incredible team here, to sound editor Susan Cronkite, executive producer John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, Kelly Frankenfield, Tony Lyons, and Christina Norman. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.